So I was a little late. I was actually coming from another meeting in Connecticut. Got stuck in traffic on the way over. So got feeling it was some of the same topics I'll cover today, a little more detail about the systemic approaches. First, I think the point that Dr. Haley raised is that sarcoma in general is a team activity. It is a group of oncologists, surgical, medical, radiologists, pathologists. Everything works as a team. As everyone else, I'm caring for nearly 23 years. I was head of the sarcoma program at Vigo. I was working on oncology years ago. I was a sarcoma program there, and we had an oncology program. But for the Memorial of Columbia, every patient seen as a team. Tumor boards, everything's reviewed. And that's the only way to really figure out how to manage these complex diseases. TGCT, even as a complex disease, a rare disease, seen by very few oncologists. In fact, you mention this disease to most doctors, and what the heck is that? But if you see a sarcoma specialist, oh yeah, we know how to handle that. We've seen that before. We have great surgeons, we have oncologists working together as a team. So that's the thing I tell patients all the time. It's a team-based approach to management. And I think the evolution of this disease reflects how many of us have worked together and try to find ways of treating and managing this rare type of cancer. But this is the typical clinical presentation. This is the patient that walks into the office. And they usually go to the orthopedic surgeon or the general practitioner, and they'll say, "Doctor, I have this painful, swollen right knee, and it hurts. I can't move it. Range of motion is very limited, and there's clear functional impairment. The patient by this time may already be on heavy dose pain medicines, tramadol, even at the point of narcotics. And of course, examine the leg, and you feel this swelling in it. And the first thing you need to get, of course, is the MRI scan. And much to our surprise, you see this large tumor. And of course, the orthopedic surgeon or the sports medicine doctor, sometimes sports medicine, more arthroscopy, and we'll see this unlivable type of tumor in the cinema. And you look at that and go, wow, that's hard to resect. Surgeon, this is the challenge, I think, that Dr. Healy and the surgeons face, that you send these patients with this diagnosis and this pathology, and you just look at this, how can you possibly take it out? And that is the difficulty of this disease. He's an expert orthopedic surgeon who really knows how to handle this type of cancer. And invariably, there is disease left behind. This is the complexity of that. Many times patients come with multiple attempts or endoscopic surgery, surgical resection, but residual disease is a problem. It's a challenging surgical problem. And clearly, we need better approaches in how to manage patients with this type of cancer. So as you know, I'm preaching to the choir, a rare tumor, 600 cases here in the United States, young adults, we see it in all ages. And what's unique about this disease is the biology of the disease. And the biology of the disease has led to really new therapeutic interventions how to treat it. There's the classical genetic translocation of the CSF1 collagen 83. We'll talk a little bit about that. And there's a predation of cells that express a receptor called CSF1, colony stimulating factor receptor. And again, here's another example of this imaging of a patient with this disease, disease of the joint. But here we have a pictorial approach that, because of this particular genomic alteration, it makes a protein ultimately called CSF1 that is secreted out of the cell into the extracellular area. And there's a receptor on the surface of these cells that constitute this type of cancer. And this receptor sits there and is stimulated chronically by this small protein called CSF1. And what was rather an interesting discovery is that could we find ways to block this? Were there, in fact, inhibitors of this receptor that could change the biology? Because you can think of CSF1 as really a growth factor, it's a food, it just feeds the tumor. It's there, it's being produced in huge amounts. And stimulating that receptor stimulation makes these cells grow and divide. So could you develop a process that would block the receptor, turn it off, just like you would turn off the ignition of a car with a key, but somehow prevent that activation from taking place? And actually, the first drug reported is one of my favorite drugs in oncology is imatinib, or Gleevec. We've known about imatinib forever. It's an inhibitor of a process of a gene called KIT. It's also APRIL and alpha beta. First reported with CML, but the GIST story is historic, revolutionized treatment of GIST, gastrointestinal tumors, discovering this mutation of this drug. But actually, imatinib hits CSF1R. And it doesn't, not even as well as some of the newer drugs, but it does have activity. And this led to several other reports. And here's just an example of a patient with a tumor wrapping around the bone here. And was put on Gleevec. Within 10 weeks, you can see that this area here is going to diminish. And by 5 months, the tumor is basically gone. And this patient actually did really well with Gleevec as an inhibitor of this receptor, an unexpected outcome of imatinib in the treatment of another soft tissue sarcoma. And actually, this went into clinical trial, and this is the phase 2 result of imatinib in patients with genomic TGC tumors and PBS. And what I'm showing you here, oops.
Computer's empty.
Mechanically challenged on
Performance anxiety.
So this is called a waterfall plot, for those of you who have not seen this one. Every bar is a patient looking at response by shrinkage of tumor. And you can see that the majority of patients actually get some degree of tumor shrinkage. If you get 100% decrease, that's a complete response. You can get 30% decrease, that's called a partial response. And so the actual partial plus complete response rate here is 19%. A lot of patients had stable disease. So the overall clinical benefit was pretty high, 93%. The response rate was considered modest because of some of the limitations we have. But it was the first attempt to block this pathway using a drug that selectively inhibits the receptor vis-a-vis CSF1 binding to the receptor and blocking activation of that pathway. This is another, just to be complete, this is another Gleevec, imatinib-like drug, imatinib, not quite as effective. But again, you see the waterfall plot. The majority of patients, because of the block the receptor, have a decrease in the size of these lesions, and 55% of this particular study patient remained on for a year. 92% had control for 12 weeks, and 77 for 52 weeks. Response rates were again not as stellar as now we're being told some of the newer agents, we'll talk about those, but some patients met that criteria for that RECIST PR. There were no CRs here, at least had 30% reduction in some patients. So that gets to what Dr. Healy was talking about. I'll go right to the newest drugs we're using today, and that's pexidartinib. I know it's PLX 3317. This is this kinome scan, and what I'm showing here is that whereas imatinib, each block on the left is the effects of a kinase. And the problem with imatinib, it hits multiple kinases, not just CSF1R, which is where the arrow is pointing to, whereas PLX 3397 really is specific for just CSF1R. So in theory, it should have less toxicity than Gleevec, because we know that drugs that have multiple kinase targets have increased toxicities in theory relative to a drug that's just one target. And Gleevec can cause ankle swelling, periorbital edema, occasionally can affect the liver, but at least we think that specificity like this should lead to increased efficacy, because it's a more potent inhibitor. It inhibits the receptor more potently, but also should avoid some of the off-target effects of a drug compared to Gleevec that can be specific hypothesis. And again, I'm taking that same patient who's in our clinic, and who's a true patient. This is Dr. Tapley, this slide set. And you can see the same woman who walked in a cane, couldn't straighten her leg, on narcotics for pain, was on this drug for 4 months, and this is one of the first pictures here. And you can see how the swelling is diminished. She actually stood up from the chair, remember this very well. So, and she could walk with unassisted, and her range of motion greatly improved, and all of her non-cognitive requirements. Right? And actually, this is the imaging of the same patient I showed you at baseline, 2 months, and 4 months. We actually had to come up with a new criteria for measurements. Usually in oncology, we use something called RECIST, which is just the length. We actually came up with the criteria called tumor volume score, because it was so dramatic that we wanted to reflect the volume of the tumor, not just the one dimension of the tumor. And this was a dramatic response, patient number 2 or 5 in the series. But it illustrates how this drug is so effective in patients with PDS. And this again is this tumor volume score here, this new measurement, which we actually come up with completely different, not been really used before in medical oncology, but we had to have something that reflected how to describe what we were seeing, because we'd never seen this before. We'd never seen these type of regressions in tumor volume. It was so dramatic. How do we describe it? So we came up with something called TVS to actually describe it for the first time in medical oncology. And you can see how we had to come up with a 50% increase in TVS, very different than anything we've seen before in cancer medicine. So it just shows how new therapies really have forced us to come up with new ways to assess how benefits can be achieved. And PVNS is a good example of that with this particular drug. And this is the first data. And remember with imatinib, we had a lot of 6% response. Well, this blew us out of the water. 79% response rate by TVS, that's that tumor volume score, in the first study we did at a dose of 1,000 milligrams per day. This was an expansion cohort. And everybody responded. So it was, how often do we see a drug in oncology? I mean, I've been doing this for 30 years. I've never had a drug where I give it to the patients and you're going to respond. Like, it's really going to work. And they said, no, it really is. They're going to feel better. That's something, I mean, Dr. Kelly and I appreciate this. We don't see it that often. When you see it, like, you just live through this, to see this repeatedly. And this is an example of great success where the biological pathway, CSF1R, is selectively blocked with the drug and have a profound effect on inducing tumor regression. We're basically taking away the growth factor, the medium, the growth, the food for the receptor that depends on this. It binds the receptor, but the receptor cannot be activated. It can't be activated, the tumor can't grow, and the tumor cells will die. And this was really an historic moment in the field of medical oncology. And not only did these patients respond, but you can look at this as the early data. This is what's called the swimmer's plot, which shows not just response, but duration of how long they're on study. And these people are on for months, sometimes actually years, though the average time on treatment was all 8 months. There are people on for 18, 20, 24 months of ongoing study. Overall response rate was 52%. That's quite high for this disease. And then about a third of patients had stable disease. So the overall clinical benefit here was 82%. So this is the phase 1 extension, but the question ultimately came up, well, what does it really mean? And despite the fact that it was historic, the FDA still insisted on the randomized clinical trial. And this is a placebo-controlled trial with Professor Darden at the dose I showed you, 1,000 milligrams per day. What it did allow is, it did allow crossover, so patients not on placebo could actually go on drug if they did a response. Everybody ended up getting the drug at some point. So this is the result of the study. It was on the Exmaritive arm, there were 61 patients, randomized trial, just see 121 patients in both arms of the study. Female male ratio here, as noted, maybe placebo. Predominantly median, 56%, 66% both arms of the study. Prior surgery, this is a disease in which many patients had significant prior surgery. They failed surgery, which is, I think, appropriate. I think there should be a surgical approach in this disease because we can cure these cancers with surgery, but again, the complexity of how do you get it out? How do you get that big tumor out? It's a hard surgical approach, but I think it's, surgical under the right surgical hands, it can be taken out, and you get very durable complete response remissions with surgery. But again, this reflects how patients come back to us, having failed surgery not once or twice, but 3 multiple times, and they were patients receiving this type of drug. Most patients had no prior systemic therapy, because there was not a few patients who had prior either imatinib or nivolumab, very few patients. So it was an untreated patient population. The majority were on some type of pain medication, and analgesic, usually narcotic, tramadol, some NSAID, and the quality of life was greatly impaired. And this is the waterfall plot to be all waterfall plots. Again, not one patient progressed on every patient here is shown from a drop formation, and complete response is 15%, partial response is 25%. The response rate here very similar to the expansion, so 35–40% response overall, 39% overall response, and a lot of stable disease that didn't meet the criteria. Because the oncologist is complicated because unless you meet that bar, so that bar across at 30%, those are the PR/CRs, but you can see even above that, all these patients don't meet the definition of a true response that we call in oncology, at 30% or more, but they clearly had clinical benefit because the tumors were smaller, they were shrinking, they didn't meet that 30% shrinkage, but if the patients had clinical benefit, they felt better, they were off their pain meds, and though the tumor wasn't gone, it was clearly small enough for them to feel better. Dr. Healy, I'm not going to show the quality of life data that Dr. Healy so nicely showed. Again, patients felt better. Maybe you didn't reach that p-value, 0.05, but there was definitely a clinical benefit that exceeded even the response benefit seen it didn't meet, the patient didn't meet the necessary CR/PR definition, but had a clinical benefit reflected by the decrease in tumor volume, tumor size, not seen in the placebo, and this led ultimately to the registration of this drug as an approval, the first drug ever approved in this disease in oncology. This is the secondary response. I initially showed this is the RECIST response, and this is that TVS tumor volume response. And look at this, it looks even better. So I think this was an historic moment in oncology that some of you may have taken this road, on the road, or comments about that, but this has become one of the most successful things in cancer medicine today. So what's the problem? Here's a patient who's showing you the benefit. What's the problem? So that's the good news, right? Wow, this is unbelievable. Why should we not give this drug to everybody? Why should there be any concerns? Well, this is the problem of the drug. And this is unfortunately, one of the issues we face is that on the study, 8 patients discontinued because of hepatic toxicity. 4 cases were serious, non-fatal, and there were 2 patients who ultimately needed liver transplant. So here's the actual incidence of hepatic toxicity. It can be as high as a third of the patients having some degree of elevation in liver function. Just 5% of elevation. So this is called transaminitis. It's usually reversible. That's the liver function test. We call it AST/ALT. That reflects inflammation of the liver. And in the paratextin arm of the 61 patient, 33% had a 3-fold elevation. That's like having hepatitis. If you have viral hepatitis, that's what you see. This is an intense inflammatory response of the liver. Now, that's not bad. Where you get the problems, you see the elevations in bilirubin. Because that means you're affecting bile ducts, and that's bad. And there's a bile duct dropout. Bile ducts, when they're hit and damaged, the ovaries go back. And then you have patients with both the high bilirubin and the AST elevation. And you see that did not happen in placebo, and then remember there's crossover, people progress on placebo. Again, about 13% of those patients had some degree of toxicity. In fact, this really only became clearly evident near the end of the randomized study. Remember, we were down to the last few patients, and the FDA actually stopped the study, stopped the randomization when it was 90% done, when this signal became apparent, because we only were seeing some of it, and then all of a sudden we have a patient with real liver failure, needs a transplant. Nobody died. But remember, this is still a pretty benign disease. People don't die of this cancer. They have pain. We don't want to give a drug to a patient who's got plus liver failure or need a transplant. That's not what we want to do. So this is an issue with the FDA. They mentioned, let the study be completed. We convince them that the benefits outweigh the risk. These are intensive liver function tests. This usually happens in the first 8 to 12 weeks of therapy. Usually you get through the first 8 to 12 weeks, you don't see this effect. We still follow very, very closely. But because of this, the approval pattern requires something called REMS, which is risk evaluation and mitigation strategy. Again, 2 cases I mentioned, one liver transplant, and I'm sorry, it wasn't like that, but we're not sure that was due to the disease or something else. It was a melanoma study that was separate from the TCT. But it is a concern with the first one. So when patients, as oncologists now, when we give out this book, we have to go to this website, we have to explain in detail to the patient this risk. And you as a patient have to sign a form, that you're informed that you're going to take this drug knowing that this risk could happen. I think as oncologists, we are so sensitive to it, we don't see a lot of it. You know, we really pick it up early before it happens. But just so you know, this is required for the FDA. Even for you to read the drug, you have to sign this form to say it's okay. I agree, Dr. Schwartz. I'm aware of the risks. I'll take the drug. Follow me the very best, and hopefully won't have a problem. And I really haven't had a problem. So, but this is just unique. What this is the problem with this drug. Well, are there other things? So what's coming up? Maybe there's something that's less hepatotoxic. Well, this is another novel CDF, CS, it's called self-limited, DCC-3014. Terrible pronunciation. I don't know how they come up with this. Horrible. They have an old nomenclature when it comes to these names, they still come out of my mouth. But this is another oral drug. It works a little differently. It's called a switch pocket inhibitor. It doesn't hit the domain, hits something off the domain. And this kind of a new class of drugs that we're seeing more and more of. And it is very selective for CSF1. I'm actually much more selective than KIT and comparable to the Plexicon. But again, definitely making a different mechanism of action. So this is the data that was being presented. Hasn't yet been published, but this is the waterfall plot from a phase 1B study in patients with PVNS. And you can see it's pretty impressive. This waterfall plot looks very much like Casartinib in terms of its benefit. Complete response rate here is, again, 53% for two cohorts. One, the patients in blue is a patient with no prior CSF1 inhibitors. Actually gave it to some patients who actually prior CSF1 inhibitors. It's interesting that if you had a prior CSF1 inhibitor and it did work, this drug could actually offer benefit because of a different mechanism which it blocks the pathway, which is actually itself pretty much the interesting stuff. But the complete partial response rate is, again, pretty high, 53%. But what about the toxicity? So we have another drug that is less toxic, because that's the critical part. Can you take a drug without worrying about having the liver being affected by a targeted therapeutic? So I'm just going to find data, I'm just going to focus on this ASC. Remember, that's that liver test, that's that inflammatory liver. And you get some of it, but nothing severe that would require a liver transplant. I mean, grade toxicity on scale 1, 2, 3, 4. Okay? 3, 4, 3 is not good, 4 is very bad. So if you look at the grade 3, 4s, in fact, there is no grade 3, 4. So it has some effects, but not to the effect that you have to worry severely about toxicity. This data, and I'll have the update, was presented this past week. Actually, this week was called ESMO. So every year, oncologists get together in the ISO called ASCO. So a lot of the studies ASCO. This week was the European equivalent of ESMO, European Society of Oncology. The data was actually updated this week at ESMO, and it looks as good as, not better, than data presented today. So the study updates go on, and at the moment there's a randomized national study called Motion Study, and it's placebo versus Vemurafenib, DCC-3014, and that's ongoing, which could ultimately lead to another drug available for patients with this type of cancer, PVNS, TCP, PGCT. And again, it may be a favor over the other drug, the Plux drug, because of the absence of hepatotoxicity. This could really change this may become the next preferred drug in this disease based on less hepatotoxicity with a very comparable response benefit to the drug test.
What do you envision the time frame being for that moving over FDA approval?
Well, I think there's an update to go right now with the FDA, but the FDA is insistent on randomized trial, and that's ongoing. So when that's going to be done, I don't know. They updated, this data set was updated this week. There's a lot of buzz with the updated data showing that this is now sustainable over now this a year later with really long, stable disease and responses with this agent that has very little hepatotoxicity relative to the the other agent. So stay tuned. Hopefully 2023, you'll see the outcome of the randomized study. And if this is as good as it looks, this could be registered within the next year for patients with this type of cancer. So this is a promising direction without the hepatic toxicity. That's the key part. You know, can this be, but the new data shows it's very similar. No wave 3, wave 1, wave 2, some mild stuff, but nothing to the point where you stop and go more that's a horrendous liver outcome. You don't want that. That's not good for anyone.
The side effects look very similar.
What's that?
The side effects look very similar.
Yeah, I mean, they're very similar. Overall, it's simple. It's a kinase inhibitor. It's a small molecule. But it's the liver toxicity that has to set. A drug to be really safe, you have to tease out hepatic toxicity. It's really, I've seen drugs not develop, but because there was no other drug in class, and we felt that we could manage it, we have to get it to the first drug. But this is coming.
Stephanie, we also have someone from Decipher. Sorry, Stephanie, to call you out. Do you know? It's like 2 to 3 years, right, for the phase 3. Do you know what the time frame is?
Probably roughly, yeah. I can't really, I'm not sure exactly the exact timing, but we're probably within the next 1 to 3 years. Yeah.
Thank you.
You're welcome.
So that gets down to other drugs we should be thinking about and what's coming down the pike. And now we talk about something called monoclonal antibodies. I'm talking really about small molecules, and this gives you a pictorial representation. Small molecule versus small. It binds to the pocket of that receptor kinase. An antibody is different. It binds completely to the receptor. Here's a pictorial representation. What it does, whereas the kinase binds to the internal activating part of the receptor, the antibody sits on top of the receptor, and by blocking the receptor, the growth factor circulates out here, can't bind to the receptor. So it coats the receptor, coats the whole cell with these antibodies. So it puts like a plastic coat around it, so though the growth factor is still being made, it can't bind to the surface of the cell because it's plastic kind of dome that covers the whole external surface of the cell. And as we're taking, CS1 is still there, still being made, but it can't bind to the receptor because the dome completely envelops the tumor cell. So they're selective. In theory, they may have fewer side effects. An antibody, when you give it, has a very long half-life. You don't take a pill every day. These drugs last in the blood for weeks, sometimes months. Disadvantages, there may be some immune effects of an antibody. They can cause some fever, especially diffusion, or some chills. Usually not permanent, usually very reversible. And in contrast to a pill, of course, has to be intravenous. So one of the drugs is currently has some excitement. This is drug and the Catusimab. Is that right? Is that close enough?
Good.
Thanks. And this is infusion given every 2 weeks to patients. They're, again, data just presented, like not published, from the European Journal of Cancer. Again, CDH age 38, but spectrum 18 to 22. In this study is mainly patients with disease in the lower limb, knee, ankle, foot, 60% require surgery. But this is the waterfall plot using MRI scan in this study. We also have PET imaging and CT imaging. And it looks, you know, it's looks pretty impressive. Right? You've got a couple of those bars that go at the bottom. Those are the complete responses, and then you have ones that are greater than 30%. Those are partial responses, and actually the PRCR rate here is higher than we saw with any oral agent. And even though we did get a complete PRCR, that's that black bar that I put to show that meets the definition of response. There are many, many patients who have also nearly PRs and a lot of stabilization of disease. So this drug, when you look at the PET-CT, but all patients have had one patient get progression at any degree on the study. This is the different colors represent different doses of the drug in this clinical trial. And not only did they respond to these patients, but respond to is exceptionally durable. We're talking about study days of patients at 900 days. 900 to 600, and that's pretty impressive with an antibody. So now we have a new drug, and with selectivity for the receptor, with an exceptional response rate, and a very durable response at that, at best. goes on, there's no comparison here to the oral agents. We can't say how this compares to oral agents, the small molecules. But this really looks impressive. Now, what about the toxicity? So this is the toxicity shown by grade. And we're only worrying about those that are over grade 3, and itching, which you sometimes see with antibody, some swelling around the eyes, not similar to something you see with Gleevec. But one thing missing from here is hepatic toxicity. No hepatic toxicity. It's not even, it doesn't happen at all with these antibodies. You see some fatigue, and look at the far bar numbers, because that was the most worried about. So again, no toxicity that requires medical intervention. But an itch response, it seems to Benadryl, something really mild, but none of the hepatic toxicities that are seen in any of the other small molecules. A couple other antibodies in development. This is a drug called MDX-05A. Again, a small study of mutations. Just press reports on tumor reduction, probably very similar to the other antibodies. And then we have this drug called pembrolizumab. Again, updated 2021. I couldn't find much data about this. 12 to 15 patients in the phase 1 study. 22 patients received it and seemed to have clinical benefit, and side effects include a number of different toxicities. But again, with the antibody, in contrast to the small molecules, no hepatic toxicity. It's just a review of the toxicities of the drugs and comparing them across the board. Again, in yellow, that seems to be the issue that we have to face. Concizumab, no reported hepatic toxicity. Pembrolizumab using antibodies, no reported hepatic toxicity. Imatinib, 5% severe. Exonerimab, 30%. We're aware of that. And again, we have Facilivant. Yes, we have grade 1, grade 2, but 0 severe toxicity. So yes, it happens, but not to the extent we see with Exonerimab, including nothing we're seeing with the antibodies. The rest of the toxicities are pretty comparable. Headache, 30%. Not reported with Pembrolizumab, 20 to 18%. Maybe joint swelling, maybe a little higher with the Concizumab compared to Facilivant. This increase in something called CPK. It's a muscle enzyme, not associated with any significant toxicity. It's more of a biochemical thing. We watch it, don't know what to do with it. We see it, we measure it. We don't really stop therapy for it, but it's really comparable across all the drugs. Rash is there, seen. Again, not that different between the many drugs. But the real issue that we really have to just follow on is this liver enzyme effects and how we manage patients with these classes of drugs. So I think that covers most of what that covers the field. I try to be complete, make sure everything is out there, and really talk about some of the new drugs and the difference between antibodies and molecules. I think as a whole, these inhibitors have had incredible effects in treatment of TGCT and MS. We do have Exonerimab. It has exceptional activity. Sees anything you've seen before, but hepatic toxicity is an issue. We have to be very careful how to use it. Small molecules, other small molecules have some degree of hepatic toxicity, but maybe not to that degree. Antibodies, I think, may be a preferred strategy in the future if the hepatic toxicity is not apparent. But again, it's cumbersome giving antibody therapy every week, or 2 weeks, or a month. Much easier to take a pill instead of a pill. I mean, you don't have to go see the doctor. Avoid it. And we'll see the randomized study. So